we've started to see changes in how common the virus is present, but we haven't yet seen changes in cancer rates. And that's because it takes, as I noted, it takes a long time to go from precancer to cancer of the cervix. But unfortunately, it's been around since 2006. As you note there, nationally, only 6 out of 10 are choosing, parents are choosing to have their children vaccinated. It's been a little bit of a struggle for the acceptance of this vaccine. It's always a struggle for vaccines, but this one in particular has met with a lot of hurdles. But slowly but surely, it's getting more and more accepted. And as I said, it is available for boys, it's available for girls, and you can see where Wisconsin is there. We're probably at about around 60%, pretty close to just the national average. But there's a couple of states that have really taken it higher, 70% or greater, a little bit in New England and California. And the hope is that, with more acceptance of the vaccine, a greater chance of having what's called that herd immunity to this virus, and less of a chance of having it move on to cancer in those individuals. So every year that we delay in prevention means, unfortunately, more individuals could suffer from this viral infection down the line. And it'd be something if it was just cervical cancer that was at issue here, but we can go to the next slide with the pie graph, please. Oh, nope. The one with the pie graph. Number 5, yep. So the other important aspect of human papillomavirus infection is that you could see it's actually associated with several different cancers. And so there's a lot of times that a viral infection causes cancer. We have that maybe with hepatitis, but in cervix, vulvar, vaginal, anal, head and neck, and penile cancer, there's all known to be an association with a human papillomavirus infection. And you could see those gray boxes that say the percentage, that's the percentage of that cancer type that's attributed to HPV. So in cervix, it's just about 100%. In head and neck, it's between 12 and 70%. In anal cancer, it's over 80%. And so not all of these cancers are really common. Penile cancer, vulvar cancer, vaginal cancer are not, but certainly cervical cancer, anal cancer, and head and neck cancer are. And you could see on the graph right next to it just how common they are. So this would be in a year, you see the total number of cases, almost 35,000 cases of HPV associated cancer in a year in the US. And so this is something that we're working to curb, because we actually have a weapon that can help us with this. So for cervix, which is the darkest blue there, there's about 12,000 cases a year in the US in cervix. In Wisconsin, it's probably about 200 a year, and the prevalence is probably about 6 in 100,000 people. So we're not the highest state by any means as far as cancer cases, but you could see head and neck is about over 12,000 for the US a year. And so that's been a steady climb. Cervix cancer has been a little bit of a, flat. We've been a little bit flat. Pap smears were discovered or started being used in the 50s. And once Pap smears were used, we really saw a decline in cervical cancer, but then it's just been kind of steady. But head and neck doesn't have a surveillance mechanism like a Pap smear. And in that population, actually, that's been steadily climbing, where now there's more head and neck cancers associated with HPV in the US than cervix. So that's been some unfortunate news. So in general, we consider that Pap smears and HPV testing are a way to prevent and do surveillance for HPV-related cervical cancer, but that the vaccine should be started at a young age, even though it's many, many years, decades, thinking about cervical cancer. But it can be a weapon against cervical cancer. I think I might have one more slide that I saw, and that was just, this slide is not specifically about cervical cancer, but because there's so much hesitancy about the vaccine, I always feel like I have to talk about it a little bit more. And this is just to emphasize that some of the biggest public health steps and successes have been through vaccination, and and increases in life expectancy have been through vaccination. And this slide kind of details, the timeline of vaccinations. And I'll just show you that in 1980s, the hepatitis B vaccine, it's 81 if I'm not mistaken there, that vaccine used to be, which was really controversial, but had crossed over and then become one of the infant mandated vaccinations and has been used for decades. And I just point out that the HPV vaccine is made in a very similar way to the hepatitis B vaccine that we give to newborns. So there is a lot of documented efficacy, safety, and it just has a lot of, it took a long time. It was released in 2006. It took a long time to get there. And since 2006, we have a lot of data still behind it, and they keep surveying it for safety. And so far, it has not been any different than other vaccines that are in the same category. So that's mostly what I wanted to talk about today. I don't know, Taquan, if you have other chat box questions that you want me to handle.
Hi, yes, I do. So I do have a question in the chat. When you're mentioning the neck cancer, are you talking about esophageal cancer? On the previous slide?
It's oropharynx cancer, so not esophageal per se. Typically, the HPV-related cancer that's in the head and neck category is oropharyngeal. So that is the back of the throat. I mean, the palate, that's a fancy word is palate, but it's kind of, just to think about it, it's kind of the back of the throat area.
Okay. And then we have another question. Although cervical cancer is most caused by HPV, can it be an increased risk if someone in your family has had cervical cancer?
That's a great question, and that is the source of study for one of my colleagues in the department. Dr. Rader studies familial links for cervical cancer, but at this point in time, it is not thought or not known to have a link that's familial or something that you could pass down to generations. I hope I'm answering that question correctly.
Righty. And then we have another. How often should one get a Pap test or the HPV vaccine as a form of prevention for cervical cancer?
So HPV vaccine, I'll take the Pap test first. So there's guidelines for the Pap test, and so they change a lot, but currently there is the guideline of after 21, an individual begins exams, can begin exams and Pap smears, and they're recommended to be annual initially, but if the patient has demonstrated that they have normal cytology, sometimes we space them out, and meaning like we give more time in between doing them. But I would say after 21, initially, they're done every year. And then after age 30, we do the Pap test is recommended to be done in conjunction with the HPV test. And so after 30, if you have both tests done and they've been negative, you have to have kind of negative for some time, or at least a couple that are negative. Then you can be moved out to having those tests done every 5 years. If the HPV test isn't done with the Pap test, you can continue to do the Pap test by itself. That is okay. And if they've all been normal, then you can go to every 3 years. So it really depends on your age, how your Paps have looked in the past, and whether or not you're getting the HPV test with it. All those components help determine what's the proper interval, if that makes sense. I hope that answers that question.
Yes. Okay, and then we have some more questions here in the chat. One question is, why is the age limit of 26 for the vaccination?
That's a good question. When they did the studies for the HPV vaccine, I mean, the reason why they picked the age 11 and 12, I mean, it wasn't arbitrary. They looked at when people might have exposure to the virus, so the advent of intercourse, when they could have exposure to the virus, and then they looked at what was the degree of response in ages. And when you're young, you have a very vigorous response to vaccines. And unfortunately, as we get older, our immune system is not as vigorous a response to vaccines. So they first say younger age gives you a better response, and ideally before you have exposure to HPV virus itself. So that's why it's given in adolescence. After a certain amount of time, if people are sexually active, they will likely be exposed to the HPV viral types that are in the vaccine. And so if that's the case, the vaccine cannot give you in a lot of people, it doesn't give you more protection than your own immune system does, if that makes sense. So if you've been exposed to all the viral types, and then you have the vaccine, which gives you second exposure to those viral types, you won't have a better response from that vaccine. It's better if you either initiate the vaccine before you see the viral types, or even if you've seen a few, not all of them, and then after they feel like most people, after they've been sexually active, and if it's been some time, they will have already seen a lot of the viral types in the vaccine. There is one recent, it was maybe 2 years ago, though, that there is kind of this additional recommendation that with a provider conversation, certain individuals may be able to continue to be eligible for the vaccine up until age 45. And so that has kind of a window to maybe increase the eligibility for people, but the CDC recommendation actually at this time still calls it at 26.
Alrighty, we have another question in the chat. Can a fetus get HPV when born vaginally?
You were cutting out. Can the fetus, did you say get exposed to HPV when born vaginally?
Yes.
Yes, actually it can. There is a papillomatosis that you could see. So this is a viral infection of infants. It's very uncommon, but it can happen where they get kind of oropharyngeal and esophageal papillomatosis from HPV viral infection, and it's thought to happen through birth. It is exceedingly uncommon, but there is a known entity that can be associated with HPV in newborns.
Alrighty, we have one more question. What are the early warning signs for cervical cancer and HPV?
So HPV it's a sexually transmitted disease, but it's different from herpes or chlamydia or gonorrhea. There aren't any symptoms typically for an HPV infection. And so getting those Pap smears done and exams done is how it is detected. But as far as cervical cancer goes, if cervical cancer is present, what's often associated with that is abnormal bleeding, possibly discharge, possibly discomfort with intercourse, possibly bleeding with intercourse. So we have a couple of signs that, we would work up. That doesn't mean if a person sees any of those symptoms that they have cervical cancer. There are other reasons for those symptoms too, of course, but certainly if a person notices those things, that's a good idea to bring it to your doctor's attention.
Okay. We have a couple more questions. How would you explain HPV to a person with little to no education?
So how I would think about it is that I use the flu analogy. It's an infection like the similar viral infection like one could get with the flu or cold. And a lot of people can take care of it themselves and they don't need any help. But in some people, it can last longer, and that's where the problem arises. So that persistence of infection can be one of the hallmarks of being a person at risk for developing cervical cancer. So if you're getting your testing done and you don't have the virus present, there's really very low risk of cervical cancer in people without the virus being present. But if you have your testing done, the Pap smear, the HPV test, and high risk virus types are present, be sure that you stay in contact or under the care of physicians so that that can be followed and monitored in the event that it needs treatment.
Mm-hmm. Okay, so we have a couple more. What if you received the vaccine at 27 years old and haven't had sex yet?
So that should be actually still a good candidate for the vaccination in the sense that if you haven't had exposure to the HPV types, you certainly have a good chance of receiving benefit from the HPV vaccine. So excellent chance for benefit. Will your response be as vigorous as it would be if you got it at 11 or 12? No, I mean, by the science that we know, no, it may not be. But that doesn't mean it's beneficial and that you won't get benefit from it. You still have a very high chance of getting benefit. The reason why I can't say it 100% is that we know people that who've gotten the vaccine can still develop an HPV infection. It's not 100%. Very few of our vaccines are 100%, but it can be still helpful.
Okay. And then I see another question. Do the percentages on the population that are vaccinated shown on the slide, so in reference to your pie chart, only include the target group of 11 and 26-year-olds?
So that is actually 11 and 12. If you're talking about the slide that had the United States on it, the pie chart was the number of cases we see in the States. So the part of the slide that had the United States on it and the shaded states, that was 6 out of 10 parents choosing to have their 11 and 12-year-olds vaccinated in the States. So maybe you were asking about different slides, which maybe I'm not interpreting the question correctly, and it's about the other slide with the pie chart. Sorry.
No, it was this one, the U.S. slide. Yep.
Okay.
Yep, the person clarified the U.S. slide.
Okay.
Yeah.
So we could do better here. We can do better. And in the United States, and it's been part of the controversy, is that this is not a mandated vaccine for school. In countries where it has been mandated, they have been able to see a decrease in HPV viral presence faster than we have. And it's happening here. It's taking longer, but it's happening. But this is not a mandated vaccine. So, and this requires parent permission. These are young young patients, so that requires parent permission, and it's not a requisite for school. So it certainly certainly then leaves the door open for parents and patients to decline, as is their prerogative. And I'm okay with people declining, absolutely. I just want to make sure people have the information.
Okay. Alrighty. Now, I believe that was the last of our questions.
Okay.
Yep, I don't see any more questions. So, Karen, you can take it away.
Okay, thank you. I just wanted to check to make sure if there are other questions that people might have, that if you weren't able to chat, you could also take the mute off your phone, off your computer or your phone. And then you can also ask the questions if you have something else that you would like to ask at this time. Okay.
Well, thank you for all the questions. I really appreciate that, and they were excellent questions.
Thank you, Dr. Uyar, for really taking the time and presenting. I do want to mention that, Dr. Uyar, we will make sure that we get the correct slides and put it on our website, because you mentioned there were a couple slides missing, and we want to make sure that everyone has the opportunity to see the slides. And so that will be a resource for them as well.
Yes, I had about 8 slides, and it had like a picture of the cervix, just because I wanted to make sure everybody knew where the cervix was, things like that. So just a little bit of background about anatomy, a little bit more about the dysplasia, and then of course the cervical cancer. And I think I was able to cover it all, but I think the picture, so I will make sure to, I'll resend my presentation
Please.
or something like that. Okay.
That would be wonderful, because we want to
Okay.
make sure that we can give everybody that's on, and also those that will eventually review, that they will get, the more detailed information. It would be very helpful. So thank you very much for taking the time out of your schedule, because I know you're very busy.
Oh, not at all. It's been a pleasure. Thank you for having me. Again, I'm one of the, so my last name is Uyar, and I'm one of the GYN oncologists, and we're at the Freighter Cancer Center, and we're happy to, some people come directly to us and some come through their primary physicians, but we're happy to help.
Dr. Uyar, I just have one more question for you, because the All of Us research program, we really believe in just precision medicine, and that's what our program really is trying to promote more of through our research. And I just wanted to ask you, as far as with precision medicine as it relates to this topic today, are there anything, or is there anything that you can add to that?
Yes, there's been a lot of change in the world of treatment for cervical cancer. So the standby for cervical cancer treatment is typically when it's very early, small enough, that it hasn't really left the cervix and it hasn't distorted the cervical anatomy too much. We can do surgery. So that's what that's ideally what we would like to be able to do. So if we catch people early enough, we do surgery. But still, unfortunately, even with screening tests and education, we still see people with advanced disease. And so advanced disease, the kind of stalwart treatment has always been radiation and chemotherapy together. But we have now this option of, with pathology and with advances, that we look for receptors called programmed death receptors in the cervical tissue. And we look for receptor presence. So if a person does have those receptors present, we actually can use immunotherapy. And that's been a big step forward for the treatment of cervical cancer, has been pembrolizumab. That's something people maybe have seen on commercials, but it's that class of drugs that's an immunotherapy drug. And so we have been able to find out from precision medicine and from pathology who harbors those receptors. And if they do have them, they are a better candidate for immunotherapy. And that's been a big help. Also, that's been being worked on in the immunotherapy realm is vaccines and other cell therapies for cervical cancer.
Can you explain to people what you mean by receptors?
So the cells of the immune system usually can identify something that's not part of the self. You know, if you have a foreign body, it usually can tell, and then it sends the cells of the immune system to kind of attack that area. But cancer has a way of kind of hiding, and it can turn off certain receptors so that your body doesn't recognize it as being a problem. And that's how it can actually kind of grow and multiply and become a tumor, you know, just go from single cells to kind of a bigger aggregate of cells and become a tumor. And so what this immunotherapy drug is trying to do is wake up the immune system, block that cancer from being able to hide from the immune system, and that way the immune system even works better to attack it. That's kind of the premise behind that.
So that's a really good, I guess by mentioning that, it's really good to know because you really hear about people having advanced cancer and you're always wondering like, why didn't the body detect it or why did it take so
Yeah,
long? So that's a good
right.
explanation.
Oh, good. Yeah, that is one of the, I mean, there's probably cancer is, that beast is kind of so sneaky, it can have a couple different mechanisms. But in certain cancers, you know, this drug has really made some strides. And so I believe in head and neck, even though I know that's not my wheelhouse, but in head and neck and in treatment of anal cancers, like this, there has been progress in treating these types of cancers. And cervix cancer had suffered from for a long time not having new therapies or new treatments or something else to offer. You know, we kind of kept using that same hammer on the same nail. So it's really nice to have an option or have other options. We'll still have the standard chemos, but it's nice to have options for people.
Most definitely. It's always good to have options.
Right, right,
The probability then increases as far as,
right.
the level of living and having a productive life. So yes, quality of life.
But the crux is finding precancer and staying in follow-up with your provider so that you could treat that precancer and keep it from developing cancer. And so even with vaccines present, it's not, like I said, it's not 100% yet, it's not there yet. And so they still have to, even if a person is vaccinated, they still should see their physicians and still should have Pap smears and testing, and always follow up for treatment if there's high-grade dysplasia.
Oh, and Dr. Uyar, if you don't mind, there was just two quick questions that came through the chat.
Sure.
The first one, what about the nature of persistent infection that puts one at risk for cancer? So just like, for example, they explained like the pathway of the infection to cell turnover to increase of the mutated cells. So that was one of the
Yeah,
questions.
I can answer that. I'll take that first then before you ask the second one.
Yeah.
So the cervix cancer is, the cervix infection from HPV, it affects a certain area of the cervix. It's right at the opening of the cervix. It's called the transformation zone. And that's a special area where cells from the outside of the cervix, which are just like the skin, like, you know, on your hand and arm, whatever, where it transitions into the canal of the cervix, because the cervix is like a long donut. So the canal of the cervix has more glandular cells. So right at that area where the cells are changing over from squamous cells to glandular cells, that area is particularly fragile. Those cells are turning over and they're just particularly fragile. And that's where the infection likes to seat itself. It has taken advantage of the fact that those cells are turning over. And how it becomes a persistent infection is that if your body has not detected it or figured out a way to deal with the infection, and like I had in the slide, having the infection is not always the issue. If we said 80% of the population will have the infection by 50, but you know, by 24 months, it should be gone, and your body then remembers, and if it sees it again, can fight it. It's when it persists. So if someone can't rid themselves of this infection and it's 24, it's 36, it's, you know, more months go by, then the virus can then get incorporated into the cells, and it actually gets incorporated into the DNA of those cells and can be replicated just when the cell replicates itself as it's meant to do. The virus then gets replicated. So there's certain particular spots where it integrates into the DNA, and then it can just replicate along with the cell, and it's a self-propagating phenomena.
Thank you, thank you. And then the last question, are there any known long-term side effects to the vaccine?
So not that we are aware of, not any long-term side effects from the vaccine that we are aware of. So the most common side effects from the vaccine are site of the injection soreness, and there is kind of this mandatory waiting time for adolescents after they get the vaccine, because they want to make sure that they're not feeling lightheaded. There's this lightheadedness associated with it, but it's also, my kids have been vaccinated and they didn't have that. But it also could be kind of part of the population that's getting vaccinated. You know, that's a young person, and vaccines are scary for everybody. So it's not clear that that's just a uniqueness to the vaccine. But it's usually kind of around the time of vaccination, the usual side effects, some pain, soreness, sometimes lightheadedness, sometimes headache, those kinds of things, but not as far as long-term effects. And I know that there's been a lot in the media. Be very careful about what you hear or read about in the media. And I know that there were things about fertility, there were things about allergic reactions, but it doesn't have any more allergic reactions than any of the other vaccines, and that's on the order of like, oh gosh, one in like several 100,000 to have an allergic reaction. So that's one thing. But all of the media that was around fertility issues with the vaccine, that they have not been proven. They have never been proven, but that's a story that doesn't get published as fast as the fertility decrease with the vaccine. Like that always makes the headline, but then the whole background story and the debunking of that, it never really makes it back to the headline. So just be real careful about what you read on the social media and wherever, and always feel like you can bring it to your provider to get the heart of the matter, because that's really, hopefully that's where people find their information from. I hope it's a good source and that it's not just social media. So if you find something out there, bring it to your provider and make sure that it's true.
I have one more thing that I would like for you to mention to everyone. What would be your recommendation as far as how often people should be more proactive in going to their physician or their doctor for checkups?
For checkups, I think there's, for women, the well woman exam actually has become really different. It used to be always, because annually you'd get a pelvic exam, you get a Pap smear. That used to be since time immemorial. I trained with that, we all did. But it's been kind of modernized recently, where people don't need the Pap smears and the HPV testing, like we said, every year. So they may put off going to the doctor and only go when they need those things. But as I tell patients that I see that let's say they have with cancer, but I think it's kind of a rule. I actually use this rule for myself, and I would say it applies to anybody, is that any symptoms that persist, and I usually use a barometer of like a couple of weeks, I would say it's time to get that evaluated. I think that, you don't want to have things that you're not quite sure if they're okay, and if they're truly bothering you, persisting for months before an evaluation. I would say things that you're not sure of, and you're concerned about, and they've been present for weeks, that is something I would bring forth to your provider.
Thank you very much. That was really great, because I know that we all need to know when we should go and see our doctor, and what are
Right.
some of the signs that allows for us to really seek out treatment.
Right. And in this time right now, it's been particularly not good for people being proactive. We see that in the offices. But just remember that, you know, it's just you gotta be your own best advocate there.
All right. Any others? Thank you so much for taking the time and explaining everything to us.
Oh, not at
Hopefully,
all.
yeah, hopefully people are armed now with more knowledge and understanding. And also, if they do have questions, they know they should seek out their doctor for those things
Yeah.
that persist.
Yeah. Well, thank you again.
Thank
I
you.
always enjoy talking about things that promote women's health. So, anytime.
Thank you. You have a wonderful day. And before we conclude, you all, we're going to just make sure that that we have our drawing. And so what we do is that we identify one person that is eligible, and I'm going to, we're looking at the letter E and Z. So the person that has the letter E and Z, we will confirm by phone or email within the next 48 hours if you have won. And once we reach out to you, you'll have 2 weeks to respond. So 2 weeks to respond. And also next week, can you go to the next one? I think, do we have another one coming up? Next slide. Next slide, Christian. I don't know.
I'm sorry, my computer froze.
Okay, that's what I was thinking.
Sorry. I
It's
mean,
not moving. But I would like to mention to you all that if you know someone that actually speaks Spanish but would like to have a presentation related to cervical cancer, it's going to be the 27th. That's going to be 1 week from today, that we will have at the same time, 6 o'clock. And then in February, we're going to have a presentation on heart disease, one in English and the other in Spanish. And that's going to be on the 24th. After this event, please take a few moments to complete the short survey or email us at allofus@mcw.edu with your suggestions. That's allofus@mcw.edu. If you can go to the next slide, Christian, if it's not, is it hanging up on you?
it's hanging up on me.
Okay. Well, my name is Karen Dodson again. We're located at 1000 North 92nd Street in Suite G150. And our phone number is 414-955-2689. And if you want to know more about the All of Us research program, you can go to allofus@mcw.edu or at All of Us MKE. And if you are interested in wanting to join, you can also go through joinallofus.org/Wisconsin. And then you can just follow the link for the Medical College of Wisconsin. And as we mentioned, this is going to be recorded, and we will be able to share the slides with you as well. And you will be able to get that information on the various websites that we'll have, and that would be our Facebook, Twitter, Instagram. So we want to thank you for taking the time out of your schedule, and we look forward to you joining us next week if you're in Spanish, and then if not, hopefully the following month for heart disease. Everybody have a wonderful evening. Thank you for joining us.